Hello and welcome. My name is Allison Craig, and I am a physical therapist specializing in pelvic health. In today's video, we are going to go over what is pelvic floor PT, what is the pelvic floor and how does it function, go over the basic anatomy and function of the pelvic floor and the bladder, and give you a couple tools to help you on your pelvic health journey. Before we begin, I want to go over some gender terminology. So when I say female throughout this video, I am talking about assigned females at birth, AFAB. And then when I say males, I'm talking about assigned males at birth, AMAB. So you may hear me saying these acronyms throughout the rest of this video. In this slide, we're going to review what is pelvic floor physical therapy and what would a session with a pelvic floor physical therapist look like. So in general, pelvic floor physical therapy is a holistic approach to addressing pelvic concerns, such as bladder bowel leakage, difficulty emptying your bladder or bowels, any pelvic pain, pain with intercourse, pre-postpartum care, and any type of pelvic cancers, such as rectal cancers or any cancers affecting the uterus, ovarian area, bladder, to name a few. In pelvic PT, there is no such thing as TMI. We are talking about sex, pee, and poop. So don't worry, you are not giving TMI when you're in a physical therapy session. What does a first session look like when working with a pelvic floor physical therapist? Like other professions, you will be filling out some history and some questionnaires to go over what your pelvic health concerns are. This will include a history of your bladder bowel function, also your sexual and pleasure function over your lifespan. We will review surgeries that could affect the pelvic floor area, affect your pelvic health. We'll also assess, general range of motion, including the range of motion of your spine, your hips, your knees, your ankles, as those all relate to the pelvic floor. And depending on what you are seeing a pelvic floor physical therapist for, and also depending on your comfort level with the therapist, an internal exam can be helpful to determine what else is going on in the pelvic area, as these are muscles that we can't see and are difficult to palpate without having a better idea of what's going on internally. So again, that is up to you as a patient on whether or not you feel comfortable with a therapist who you are working with. So they should be somebody who really talks with you, explains what they're doing, explains the purposes of the exam, and then you are in charge of whether or not you would like to proceed with that. So if a pelvic exam is necessary and helpful, and if the patient is also agreeable to that, for people who are assigned female at birth, I like to say it's equivocal to a gynecological exam where we are looking at the pelvic floor through the vaginal canal. However, typically there is no use of a speculum. Some physical therapists do like to use that if they are looking for something to help with further diagnosis. However, I personally use a gloved finger as I find that that is more comfortable for patients. As a physical therapist, we are looking at how the pelvic floor muscles function. We're going to have you cough, sneeze, see how your pelvic floor is moving as you do those certain motions, maybe do a couple little exercises to see how the pelvic floor moves. We are testing the strength, so the ability for the pelvic floor to contract. We're also looking at endurance. How long can you hold that pelvic floor contraction? And also the ability to relax the pelvic floor. We'll also be palpating for any areas of tenderness, just like other areas in our body. We palpate your neck, we palpate your back, looking for any areas of tenderness. Those are the same things we're looking for in the pelvic floor. And then last thing, typically we're testing for any scar tissue that is present, looking at how that scar tissue moves, if that's applicable. For assigned males at birth, a rectal exam would be the way that we can look at the pelvic floor there. I will also say for people who are assigned female at birth, a rectal exam can also be helpful depending on what's going on. If somebody has issues with the tailbone, say you've fallen on your tailbone or you've fractured the tailbone, that can be an area that we assess. It can also be helpful for people who are having any kind of bowel concerns, such as constipation or fecal incontinence. And so in the same thing, when we're doing a rectal exam, it's a gloved finger. We're palpating around the external area and also a little bit in the internal area. And physical therapists are looking at the same thing. How do the pelvic floor muscles function, especially when you cough or sneeze? Testing your strength, how long you're able to hold, how strong are you able to hold, how long are you able to hold, and your ability to relax the pelvic floor. Also palpating for any areas of tenderness on the backside and testing for any scar tissue and the way that scar tissue mobilizes. So what is the pelvic floor? The pelvic floor are muscles that attach to the front of the pelvis, so here in the pubic bone area, to the back of the sacrum. So they create this nice bowl or hammock for all of our organs above. These are most commonly known as muscles that we use for Kegels. The word Kegel came from Dr. Arnold Kegel, who was a doctor in the 1950s, who wanted to try and help people with their urinary incontinence symptoms without having to do surgery. And he found that when people did these contractions, contract, relax of the pelvic floor, that significantly reduced their urinary symptoms to where they didn't have to have surgery. So a Kegel is simply a pelvic floor muscle contraction and relaxation. So throughout the rest of this video, I will be saying pelvic floor muscle contraction and relaxation. If you know the word Kegel, that is also a Kegel. So I may interchange that throughout the rest of this video. And to take a quick look at the anatomy over here, this is an assigned female at birth. So we have the urethra here, the vagina here, the anal canal here. And everything else in this red is muscle. So we have the levator ani, which is a muscle that slings all the way around from the front of the pubic area to the back, to the sacrum, the coccyx. We also have the coccygeus, which is a muscle that connects from the coccyx area to this side of the pelvic bowl. And then we also have the piriformis. I like to really point this one out because oftentimes people have back pain and the piriformis can be part of the reason for the back pain. And it is right here in the pelvic area. So any type of back pain can also affect the pelvic area. And lastly, the obturator internus. This is a small muscle that helps with hip mobility. So it helps us move our hips out. And a lot of times we will assess how that hip range of motion is and see if there's any tightness or decrease in strength in that area. In this slide, I wanted to show an assigned male at birth here. We've got the urethra and the anal canal as well. And everything in red is the pelvic floor muscles. So they have, assigned males at birth have the similar orientation as females. As far as the muscles go, they are the same. There's just no vaginal canal. In this slide, we're looking at the pelvic floor from the side. So we're cutting ourselves in half, and this is what it looks like. So the pelvic floor muscles support the organs above the pelvic floor. So these organs include the bladder and the urethra. Here's the bladder and the urethra for AMAB, assigned males at birth. The uterus and the vagina, and the prostate over here, and then the rectum in the back, and the rectum in the back. I also like to point out in this slide, we have the sacral plexus right here. So this is where the sciatic nerve comes from. It is deeply oriented, close to our pelvic floor, and so oftentimes when people have back pain, like I said in the prior slide, they can have issues with the pelvic floor. So this is an area that a pelvic floor physical therapist would really look at and assess how your back is moving, any pain associated with it that could be contributing to the pelvic health concerns that you have. In the next few slides, we're going to be going over the diagnosis called pelvic floor dysfunction. Pelvic floor dysfunction is defined as the difficulty in relaxing and coordinating your pelvic floor muscles to allow for full emptying of the bladder and bowels. Women, men, and children can experience pelvic floor dysfunction, so all people. The symptoms of pelvic floor dysfunction are vast. They can be lots of things. It can include urinary incontinence, which is bladder leakage, fecal incontinence, leakage of the bowels, difficulties controlling your gas, pelvic organ prolapse, which we will go over in a slide later on, pelvic pain, difficulties emptying the bowel or bladder, pain with intercourse. So a litany of symptoms. Why does pelvic floor muscle dysfunction occur? It could be that the pelvic floor muscles are too weak. Your muscles aren't contracting as strong as they could be. There also may be a delayed response to contracting. Say you cough or sneeze and your pelvic floor is just a little too slow to absorb and contract with that quick amount of pressure that's happening. This can lead to loss of bladder or bowel control, causing accidental bladder or bowel leakage. The pelvic floor muscles may also be too tight. So a tight muscle is not a strong muscle. Similarly to the neck, when our neck is really tight, we have less range of motion and we're slower to respond. If we have tight muscles in the pelvic floor, those muscles are going to be slower to respond in the same way with that cough, laugh, or sneeze. It might be a delayed response. It might not be able to relax all the way to be able to absorb that pressure and rebound back. Some signs of too tight of a pelvic floor can include pain in your low back and in the pelvis and the hips. You could have urgency and needing to pee frequently. There can be bladder pain or difficulty with emptying your bladder when you go to the bathroom. You can also have pain with bowel movements or constipation if you have trouble emptying your bowels, and also pain while having sex. So factors that affect the pelvic floor. Things like bearing down or straining during daily activities, such as lifting really heavy boxes with not great mechanics, like this gentleman over here. That can put a lot of pressure on the pelvic floor. Every once in a while, that's not going to be a big deal, but a lot of the times it's the repetition. And if you're carrying too heavy a load, then you are strong enough to hold. Constipation is another one. So same thing, if we're constipated, a lot of times we're bearing down or straining to be able to have that bowel movement. That can affect the pelvic floor and put a lot of pressure on the pelvic floor. It can also create that tightness. And then, like I said, heavy lifting. This is different than if you're at the gym and you're working with a trainer or you have the skill set and know correct body mechanics when you are lifting and say you're trying to get to your 1 rep max. Hopefully you've been doing this progressively and that you're working on strengthening those muscles and not going from 5 pounds to 100 pounds. It's that gradual resistance. If you're lifting heavy and you don't have that training or you haven't been experienced with lifting heavy in your life, that can be a different story. So that could affect the pelvic floor. Other lifestyle factors that can contribute to pelvic floor dysfunction are chronic coughing. So especially during post COVID days, there are a lot more people who are having this chronic cough. So coughing over time, that constantly is putting pressure down on the pelvic floor and can create some pelvic floor muscle dysfunction. Other lifestyle things such as smoking. It's not just the coughing part, but also the nicotine can impact the bladder lining. Physical inactivity, so lots of sitting, just like the rest of our muscle groups, when we are not as active, those muscles get weaker and less able to contract and relax. And so same thing that happens in our pelvic floor. And there are also certain foods that can irritate the bladder and bowels. Generically, caffeine can affect a lot of people, a lot of bladder issues. So that's something to note. If you drink coffee or caffeinated tea in the morning, you may find that you go to the bathroom more frequently because caffeine can be a bladder irritant. It is not necessarily an irritant for everybody, so it's something to just notice. Other factors that can affect the pelvic floor too, menopause. So for women, the average age of menopause is 52. That being said, there are plenty of people who go into menopause much earlier in life. It could be because of surgical intervention, having a hysterectomy that can change the way that our hormones are in our body. With the decline in estrogen, there is a decline in how the pelvic floor muscles can contract and relax, as well as the other muscles in our body. So decline in estrogen definitely can affect our pelvic floor. So there are things that we can do to help maintain as best we can as we go on later in life. And there are some other medical options that can also be helpful, such as vaginal estrogen like Premarin and estradiol, or there can be other systemic medications that can also be helpful. These are all great conversations to have with your primary care provider or your gynecologist. There are medications that can affect the pelvic floor, such as Lasix. If you have any kind of cardiac medications, that can affect the amount of urine output that you have. So you're having to go to the bathroom more frequently. That is just one of the examples. And age, which as we age, our body changes, and so does our pelvic health. So we have to have a little bit more maintenance than we do when we're in our 20s and 30s. In this slide, I wanted to briefly go over what pelvic organ prolapse is. Pelvic organ prolapse is when one of the organs are lowering down in the vaginal canal if you are AFAB female, or for AMAB, males at birth, there can be some pelvic organ prolapse too. In AFAB, there's the bladder that can lower down into the vaginal canal. There can also be the uterus that lowers down into the vaginal canal. And there can also be the rectum, where the rectum is lowering into the vaginal canal. So that is called a rectocele for the rectum, a uterocele for the uterus, and a cystocele for the bladder. Oftentimes when people have pelvic organ prolapse, they'll report symptoms of heaviness in the pelvic floor. They'll feel like something is falling out. They'll feel maybe like they're sitting on a golf ball. Especially for a rectocele, people will feel that they can't empty their bowels all the way, like something's being pushed into the vaginal canal. Or for males, they might feel it lowering into the perineum, so that space between the rectum and the scrotum. Those are examples of what some symptoms might be. There doesn't always have to be pain with this or leakage, but sometimes it can be associated with bladder leakage or bowel leakage as well. A gynecological exam or an exam with your primary care provider or someone who can look at the organ prolapse can tell you to what extent the prolapse is happening and which organ it may be. For people who have had babies, oftentimes people will have a small amount of prolapse depending on how many births they've had, and it may or may not necessarily get worse. It just depends on life factors. There are plenty of things that can help, including pelvic floor physical therapy, where we can help you with learning how to get those muscles to be a little stronger to help to support the bladder. And there are also other medical options as well, such as pessaries. That is a device that is like a cylinder, and it's placed in the vaginal canal and creates a little brace for those organs. That is a nice option. It may not always be helpful for some people, but for a lot of people, it is a great option that isn't surgically necessary if needed, and it's something that you can take out and put back in. It is often most helpful for bladder and uterine support, but it can also be helpful for the rectum as well, depending on if you're constipated, it may not be as helpful, but there are options, and that would be finding a provider who does fittings for pessaries. Also, there are some other medications, such as the vaginal estrogen, like I said before. Vaginal estrogen is a cream-based option where you just squirt like a little pea-sized amount of this like lotion for the vaginal canal, and you just place your finger in the vaginal canal and move it in that area. That helps to support the vaginal tissue, creates a little bit more strength in the vaginal canal, and also can help with vaginal dryness that can be associated with pelvic organ prolapse. So those are a few things that are non-surgical options to help with the prolapse symptoms. I always recommend pelvic floor physical therapy prior to having surgery to build at least that muscle strength. Even if surgery is necessary, it is great to have an idea of what to do for prehab, and then post-surgical, what are some things that you can do as well. On this slide, I am showing you the pessary. So you can see here, it's just that cylinder is placed in the vaginal canal and it's creating support for the bladder here. Also, you can see how it's creating a little support for the rectum here. So it's kind of pushing that out so that things are staying up a little bit better. And over here, this is one that has a little nodule at the bottom, and it is supporting the uterus, but you can also see how it's giving a little support for the bladder and also the rectum here too. So pessaries can be a great option prior to doing surgery. Briefly, we're going to go over bladder function and how the bladder works. We've got the kidneys, the ureter that comes down here into the bladder, and then the urethra. And this is an AFAB, female at birth. We've got the uterus and the fallopian tubes and the ovaries here. The bladder holds urine by stretching, and the pelvic floor muscles stay contracted to allow for that urine storage. And storage capacity is about 2 cups. So that's quite a bit of fluid. Some people do have smaller bladders. However, for a majority of people, there's that storage capacity of about 2 cups. So with normal fluid intake, we should urinate about 6 to 8 times a day. So that comes out to about every 2 to 4 hours. And normal fluid intake is about half your body weight in ounces. So I weigh 160 pounds. That's about 80 ounces of water a day. Now you can get that water intake from, fruits and vegetables that you eat, soup, any kind of fluid. However, water is the most ideal amount of fluid intake. This is a general guideline. Some people, that might be too much depending on your body weight and height. So within reason, it would be a good thing to talk about with your provider on what the right amount of water fluid intake would be for you. For normal nightly routine, anywhere from no times waking up to 1 time a night to wake up. If you're waking up more than 1 time per night, that could be a sign that the pelvic floor is too tight and you're not fully emptying your bladder all the way when you go to the bathroom. It could be that you're drinking a little too close to bedtime. It could be medications that are affecting the pelvic floor. Could be prostate issues. It could also be behavioral habits. Oftentimes, if you are waking up more than 1 time per night, some good things to check in on are maybe avoiding any significant amount of liquid intake about an hour or 2 hours prior to going to bed. If you do wake up and feel like you need to go to the bathroom, but you just went to the bathroom maybe an hour or 2 before, see if you can distract yourself and get back to sleep. That is hard. I know that is very hard. So there are a couple of things that you can do to distract yourself. Sometimes putting pressure on the pubic bone can suppress that urge. Counting from 1,000 backwards. Some people put on music, or there are lots of things that you can do to distract. The amount of urine that we should be putting out is about 1 to 2 cups. So again, our storage capacity is about 2 cups. That's how much we should be able to void. So another way to think about it is 10 to 20 seconds. So if you're going to the bathroom, 1,000, 2, 1,000, 3, 1,000, that should be as much as you stream, anywhere from 10 to 20 seconds or more. If your stream is less than 10 seconds, that means that either you're not emptying your bladder all the way, or you went to the bathroom too quickly before needed. A bladder diary can be really helpful for not just your provider, but also for you to be able to track what's going on in your day and be able to determine what are some of the contributing factors that might be contributing to your pelvic health concerns. So a bladder diary is looking specifically at the bladder. So things that you can monitor is, how many times do you pee in the day? What times? Are you peeing more frequently in the morning versus the afternoon? Did you have at least 2 hours between the trip to the bathroom? And then can you count to 10 each time you pee? So how much output are you putting? Is it just a trickle, or is it a full bladder emptying? How much did you drink? Hopefully more water, ideal. But if you did drink some coffee, how much coffee was that? And then did you have any leakage? What was happening when you had leakage? Were you walking to the bathroom, so that urgency, or did you sneeze or lift something? Laugh. After you went to the bathroom, did you dribble a little bit when you stood up? Exercise, things like that. And then how many times did you get up at night? Monitoring that. Those are a few of the things. I will have a link below to give you an example of bladder diary that you could do for yourself. This is a great thing to do prior to going to see your pelvic floor physical therapist if you can, or prior to seeing your medical provider, a urologist, a gynecologist, if you're going to be seeing them about your bladder concerns. This can be a really helpful tool for you and your provider to determine what the best route would be to help with your bladder concerns. We're going to go over types of incontinence. There's stress incontinence, there's urge incontinence, and then there's mixed incontinence, meaning of the two. You have both stress and urge incontinence. Stress urinary incontinence is the unintentional loss of urine with any type of physical activity or increased pressures, such as a cough, laugh, or sneeze, jumping, exercise, anything where there's a lot of impact on the pelvic floor. So if you are somebody who crosses your legs when you sneeze, that is an indicator that you have stress urinary incontinence because you're trying to squeeze everything so you don't pee your pants. Urge urinary incontinence is that unintentional loss of urine with urgency. So the second you get that urge to go pee, you cannot do anything else. You're running to the bathroom as quick as you can, and you're starting to leak as you're getting to the bathroom. Or you get to the bathroom and you see the toilet, and then all of a sudden you start to pee a little bit and you're not on the toilet. Or you're pulling your pants down and you're starting to dribble a little bit. That's urge incontinence. Another one that is sometimes quoted is a key and lock syndrome. So you're driving home, you just did a bunch of grocery shopping. You may have gone to the bathroom when you went to the grocery store, and then you're coming back, and then you've got your groceries in your hand, you're putting your key in the lock, and you have a sudden sense of urgency. Got to go to the bathroom now. You drop the groceries and you run to the bathroom. That's key and lock syndrome. So a couple things to help with this urge urinary incontinence. Distraction techniques, just like I talked about with nighttime frequency. If we place a little bit of pressure on the pubic bone, that can decrease that reflex that's happening in our brain when we get that urge. So it can suppress that reflex a little bit. Sometimes doing little heel raises where you're just lifting up and down, going up on your toes, that actually can activate the pelvic floor a little bit and can get some relief from that urge. It's also a distraction tool. There is also breathing. So just taking a couple nice deep breaths in and out. With that deep breathing, we are bringing on the parasympathetic nervous system, so that rest digest, because when we have urge, our sympathetic system goes way up, so that fight or flight, like we got to go now. Using that breathing can help with bringing the parasympathetic system on board and helps us calmly get to the bathroom so that we can go to the bathroom. Before we move on to some exercises, we're going to first talk about what the core is. We're going to look at the core as a canister. Starting at the top, we've got the diaphragm right here, which is underneath our rib cage. It's what helps us inhale and exhale. We've got our abdominals here, more specifically our transverse abdominal muscle, which is the girdle muscle of the abdomen, meaning it's the deepest layer, abdominal layer. It attaches from the front and comes all the way around to the back of the spine. And then on the backside, we have our smallest lumbar spine muscles called the multifidi. They help with rotation and side bending. And then lastly, at the bottom, we have the pelvic floor here. So you can see it attaches from the abdomen here all the way to the tailbone. So that is the 4 core muscles that we're going to be talking about. So one of the exercises to improve our pelvic floor is actually just breathing. Because of how our breathing works with the diaphragm and the pelvic floor and the abdomen and the back muscles, that actually helps to promote improved pelvic floor mobility. It helps us figure out how to lengthen and relax the pelvic floor, as well as able to contract the pelvic floor. So there's a lot going on in this picture. So we're going to break it down a little. On the left here, this is showing our inhalation. So when we inhale, the diaphragm right here is lowering down into the abdominal space. Ideally, our abdominals are relaxing to allow for that absorption as the as the diaphragm is lowering down. We want our abdominals to relax to allow for more space in the belly. The pelvic floor is also lengthening and relaxing to be able to absorb that pressure, because if the pelvic floor stays really tight, that pressure continues to increase in the abdomen and there's not very much space for it to go. So that pressure pushes down on the pelvic floor, which can create some of that incontinence, that bladder leakage, that pelvic floor tightness. So we've got to learn how to let go, relax, lengthen that pelvic floor. And then lastly, over here, the back muscles, they are also lengthening and relaxing as we're inhaling. On our exhale over here on the right, as we exhale, the diaphragm returns back up into our rib cage. The abdominal muscles pull back in towards the spine. The lumbar multifidi muscles here also contract, and the pelvic floor muscles lift up and contract. So without us having to even do a Kegel per se, right, that pelvic floor muscle contraction, just by breathing, we're getting the ability for the pelvic floor to lengthen and contract by just using our breath. So it's a little bit of this, pat your head, rub your belly kind of thing. It takes a little bit to understand this breathing mechanics, because oftentimes when we are upright, walking around doing our thing, we tend to hold a lot of tension in our abdominals. We tend to kind of keep them engaged all the time as we're running around doing things. And especially if we're really stressed or we've got a lot going on, we tend to tighten everything up. So our breath becomes a little more shallow, increases more pressure in the abdominal area, And just incrementally over time, that can put a lot of stress on the pelvic floor. And we're talking, years of building up. Every once in a while, we need to have that core stability as well while we're breathing and having that tightening. There's a time and place for it. When we're doing just everyday activities, ideally, we're getting that abdomen to at least relax a little bit as we inhale and exhale. So in this slide, we're looking at animated version of what's happening on the inhale and exhale. So to get oriented right here, this is the diaphragm. So we've got the lungs on top. This is our rectus abdominis. So our deeper abdominal muscle layer is not shown here because that would, then we wouldn't see what's going on here. And then we've got the pelvic floor at the bottom and our low back muscles here. You can see that as it's breathing, we're inhaling. So on the inhale, the diaphragm is lowering down, the pelvic floor is lengthening, the abdominals are relaxing and kind of pushing out, and then the the lumbar muscles, multifidi, are relaxing as well. And then on our exhale, everything is pulling up and in. So again, abdominals come in, pelvic floor lifts, multifidi come in, and the diaphragm lifts. So there's an inhale, everything's relaxing. Exhale, everything's contracting. Inhale, relax. Exhale, contract. So now we're going to go through how to correctly do a Kegel pelvic floor muscle contraction. So I want everyone to start by sitting up towards the front edge of the chair with your feet flat on the floor like this picture here. So we want to try not to have any back rest support. From here, if you are AFAB female, I want you to notice your vagina resting on the surface of the chair. If you can't feel that, just kind of rock back and forth and just notice if you can feel at least a little bit of pressure in generally that area, because we're going to bring a focus to that area. If you are AMAB male, you want to feel the area between the rectum and the scrotum, that perineal area. So that's a little bit of visual imagery. I want you to imagine that there's a stone, nice soft round stone, a diamond, ruby, smooth stone that you're going to skip on the water. So imagine that stone is just resting at the entrance of the vaginal area, or again, right at the perineum area. From here, let's just keep that stone in your mind for a moment. What we're going to do is take a nice deep breath in. So we're inhaling through the nose, and I want you to notice if you can allow your belly to relax, or I wrote here, rise, right? So the belly's extending out a little bit. And then I want you to notice if you can feel a little bit of the vagina lowering down into the chair surface, or again, that perineal area into the chair surface around that stone. And it might be a really subtle movement. You may not notice anything, and that's okay. It takes a little bit of practice. So next, as you exhale, I want you to imagine that vaginal area or the perineal area is just gently grabbing that stone and pulling it up and in. You're trying to lift it maybe a centimeter off the chair. It's not going to lift too much. So we're just focusing around that vaginal perineal area. Hold it for as long as you're exhaling. And then on the inhale, you're going to inhale again back through the belly, lowering that stone back to the chair surface. So there's a lot of cues there. I will have the cueing and a little handout for you in the notes below so that you can read through it. A couple things to take a note of. Try not to squeeze your butt. So if you feel yourself lifting off the chair when you're trying to do that contraction, you're doing that too much in the gluteal muscles. You want to just gently focus on that vaginal perineal area. The other piece is try not to flex your abs too hard when you're exhaling. A lot of times we're trying to get that really strong pelvic floor contraction, so we're really engaging in our abdominals. It doesn't need to be a very big contraction, just enough to where you feel, again, a little lift. And then the last piece is really making sure that you're completely relaxing the pelvic floor and letting that stone go, that imaginary stone, go all the way down into the chair surface. That oftentimes is the piece that people are missing, is that full relaxation. And if you aren't able to get it right now, it takes practice. It takes practice. It probably took me a good month or two of really getting the coordination and thinking about it. Again, it's that pat your head, rub your belly thing. Most of us are not used to breathing this way unless you're a singer or you've had practice with that diaphragmatic breathing. Majority of the time, most people are breathing more here into their upper chest, and there's not a lot of belly movement, especially when we're upright. If you do find that getting that belly breathing is a little too hard sitting, you can also practice it laying down. Oftentimes that helps get the posture muscles out of the way, and it helps you focus more on just the belly. All right, we're gonna do that breathing exercise a few times through with me cueing you so that you can get that repetition in. So again, starting towards the front edge of the chair, I always like to place one hand on my belly, one hand on my chest, just to have that tactile input to notice where my breathing is happening. And we're going to start with that inhale, belly rises, pelvic floor relaxes. Exhale, pelvic floor contracts, lifts up, abdominals tighten just a little bit. Inhale, belly relaxes, pelvic floor lengthens down into the chair surface. Exhale, lift the pelvic floor up and off. You're lifting that stone. Abdomen pulls in. Inhale, relax. Lower the stone all the way down into the chair surface. Exhale, lift that stone up and off the chair. A few more repetitions. Inhale, relax and lengthen. Exhale, lift up and in. Check in that you're not squeezing your glutes too much or squeezing your abs too much. Inhale, relax. Exhale, contract. One more time. Inhale, relax. And exhale, contract. Thank you so much for joining me. I really hope you learned something new, and if you have any questions, please feel free to reach out to a pelvic floor physical therapist near you.